It's getting close to 6 p.m. Welcome to our Rendr monthly educational program. I'm Michael Poon. I'm a staff member of the Rendr Cardiology. Today, I'm going to talk about advanced cardiac imaging for the PCP. And this is a topic that most PCP probably never get a chance to listen to. So I thought it would be a good opportunity to share with our PCP the kind of imaging work that we do in cardiology. This is next to the last talk for the year for this cycle. Next talk will be the last talk of this cycle, and it will be given by Pam Noack, who's director of our research program, and she will talk about how to start a clinical trial within Rendr. So today I'm going to talk about advanced cardiac imaging. Everybody's like advanced cardiac imaging because the pictures tend to be very pretty. And you see the nice pictures in three-dimensional format. But actually, it took many, many years of hard work to get to this stage. I will start off by talking about a common cardiac chief complaint for PCP. And this is important because this is what lead the patient to my office. And most of them came with one or more of these symptoms: chest pain, shortness of breath, exertional dyspnea, palpitation, dizziness, syncope, peripheral edema. This all related to the pump, the heart, having problem, either blood supply to the heart or the function of the heart. So this is important. How we cardiologists take it from there after you refer a patient to our office, what we can do to evaluate this patient. And if you look at this diagram that I have here, most symptoms will lead to echocardiogram. Most patients came with an EKG done by their primary care physician already. And they either detect some abnormality or some changes, and the patient was referred to see a cardiologist. And in the cardiology office, we do echo, and which is like bread and butter, and which allow us to see the function of the heart and to evaluate the various structure of the heart. A more detailed diagram, Dr. Teresa Lai, who's currently working in my clinic, is helping me to develop this into a more user-friendly form. And the goal is to set up some kind of flow diagram to show the various diagnoses and how it lead to what kind of cardiac workup. And I think this is will be very important because I'm a very much a data-driven person. I like to see with this flow diagram, will we be able to, in the future, provide better quality of care if we could standardize the approach and at the same time save the rising healthcare costs. So this is something that's work in progress. If you look at an echocardiogram, the two most important questions after we perform echo is, what is the function and what is the structure? And the function of the heart is everything in cardiology. And if the function is no good, really everything is going to be problem for the cardiologist and the PCP. Unfortunately, the test that we use the most in the cardiology office often not able to give us a good picture that we need. And sometimes we give a guesstimate of the function and not really the accurate functional assessment. So that's the limitation that we have to declared from the get-go. Like this echo that I show you here, you can't really see the apex too well, but we still have to give a LV function based on the study. And sometimes cannot show the complete picture of the heart, and we sort of have to wing it, so to speak. Well, that's the reason we need advanced cardiac imaging, and I call it the crystal ball of medicine, the two most important imaging modality in medicine. The CT scan won the Nobel Prize in physiology in 1979. MRI won the Nobel Prize in 2003. So that shows you that these technology are very important and make a big difference in the history of medicine. So if you look at a CAT scan, this is a CT scan, and you open up the hood, so to speak, you see an X-ray source and you see the detector row on the other side, and the patient goes through the middle part of the gantry, sort of the donut hole. And the X-ray rotate at a very high speed, and with the high resolution detector, you'll be able to see the structure of interest very, very accurately. The picture on the right is the scanner that we have currently in Brooklyn. So it's doing a lot of good work for us every day. Yeah. Whoever is not talking, can you mute? You are making a lot of noise. Thank you. So non-invasive coronary angiography, the four top indications are evaluation of chest pain, and either elective or acute, and the evaluation of shortness of breath, which is a very common symptom we see in the cardiology office. And lastly, is suspected coronary anomaly. Before I started doing cardiac CT, I always thought that it's not that common to have coronary anomaly, and I was wrong. And now we see coronary anomaly almost once a month, if not more often. To just show you that, some of the things that without the technology, we took it for granted that it doesn't happen that frequently, but in fact, it happened quite a lot. Well, these are the statistical analysis to show that CTA, these are the statistical graphs showing, based on many studies that published in the past, that CT is the most sensitive and has the highest negative predictive value. What it means is that if you have a negative CTA, you can almost be rest assured that the patient has no significant obstructive coronary disease. And that is very, very reassuring and important. Telling a patient who just finished a stress test, everything's okay, is really not very reassuring. And we have seen patients after stress test suffer a heart attack that evening. So stress test is not perfect by any criteria. CTA, because it's an anatomical test, seems to be able to give us a lot more important information for the management of the patient. So this is the CCTA on the bottom, a patient lying comfortably on a couch, ready to be transferred into the gantry. And on the top is the sort of scary operating room where cardiologists perform angiography, catheterization. So you can see the big difference, and they pretty much offer something very similar. Both of them give you an anatomical look of the human coronary. which is very important. So 20 years ago, when I first started CCTA in this country, and I saw these images, and I said, wow, this is going to change the way that we're going to manage coronary artery disease. This particular technology, with the ability to visualize the human coronary non-invasively, is such an important contribution in medicine. So we hope that now, before you go to the cath lab, you need to go through the gatekeeper. And the gatekeeper is the CTA. So you can see two very nice pictures, one colorful on the left that show you the coronary artery in a real patient, and the other one to give you the more detailed look of what kind of plaque is obstructing the coronary. In fact, this picture you cannot even see in the cath lab because the invasive catheterization, although it has a very high spatial resolution, it is not very good in tissue characterizing what is obstructing the lumen. CT is by far much, much better. So you can see that this patient has a calcified white plaque sitting at the proximal portion of the coronary. This is very important information because now you know this patient needs to be on medical therapy and be very careful to make sure that this individual keep the bad cholesterol and the triglyceride and the hemoglobin A1C and the blood pressure all within normal range. So a patient with an equivocal stress test, as I said before, someone who finished a stress test, by no means you can be sure that the patient's not going to have a heart attack. And this is a case. A patient had a negative stress test. It read as equivocal because the patient was not able to get the heart rate up to the level, but it's close enough. So they call it equivocal. And the nuclear portion of it shows a small reversible apical ischemia. And the patient went on to get a second opinion because the patient was not comfortable with this chest pain, but it appeared to be not such an abnormal nuclear stress test. And the patient had a CTA, and this is the picture of the CTA. And it turned out that this patient had a complete normal coronary. So that little apical defect that the nuclear cardiologist saw on the scan was an artifact. And even though the patient was not able to achieve adequate heart rate, the coronary is completely pristine. There's not even one plaque sitting anywhere in this patient's coronary artery. Another common question that we face from the PCP is that, Dr. Poon, this patient has a new left bundle. I don't know what to do. Should I send the patient to the emergency room? Is this possibly an MI? Well, of course, it's possible. In the old days, before CTA, we might have no choice but to send the patient to the emergency room for serial enzyme and EKG, echo to look for warm motion. But now with the CTA, we can just do the test and look at the coronary and see what's going on. And this 46-year-old male with a new left bundle and some atypical squirrely chest pain and negative stress echo, they turn out to have very severe obstructive coronary disease, as shown here. You can see the blockage in the proximal left anterior descending, very severe. We sometimes call this a widowmaker because if this blood vessel closes, you die. So it's pretty serious. So this new left bundle turned out to be real serious. And then if you look at the detailed look of this plaque, you can see the calcium and the soft plaque sitting around the lumen, obstructing the lumen, and the blood barely able to crawl through the lumen. And this patient was sent to the cath lab for intervention. What about patient with chest pain acutely? And we get that too. Some patient sent from the PCP office say, look, this lady just walked into my office with sudden onset or new onset chest pain. I don't feel comfortable, just let her go. And we see the patient, we do the test, and this patient had a calcium score that was 0. So you would think that calcium score 0 is pretty reassuring. And because the patient was sent to the emergency room, they did also a lot of blood tests, including troponin, and was negative. But when you inject the dye, you see something very different. This 78-year-old female has an obstructive proximal LAD disease. Although the calcium score 0, that doesn't mean that she doesn't have soft plaque that is obstructing the lumen. So the take-home message is basically, if you have symptoms, you should not use calcium score. You should inject dye and look at the lumen. But this patient with a 0 calcium score turned out to have high-grade stenosis. And she was sent to the cath lab and had a angiogram done, and the stenosis was opened up in the cath lab. So you can see the same obstruction here, similar to what the CTH show. Again, you don't see the soft plaque and you don't see the calcified plaque. All you see is what the contrast allow you to see, and which is the narrowing. And the patient had a stent, and this is the after picture after the cardiologist, the interventional cardiologist, put in a stent, open up the stenosis. Well, there are studies published in the past 10, 15 years. These are all randomized controlled study in support of the use of CTA in the acute setting. So it doesn't matter whether it's in the emergency room or in the cardiology office, if you have the capability, like what we, Rendr, cardiology is able to provide, which is we can do a CAT scan immediately on a patient. You know, if the patient does not have any renal insufficiency, and a lot of insurance now do not require pre-authorization. In fact, today we had a patient sent in from another cardiologist, a different cardiologist in the area, walk in, you know, and it turned out the patient has severe widowmaker stenosis. That just to show you having such capability is very important, is potentially life-saving. So the randomized control study, the 3 that I show you, and I did one when I was at Stony Brook, all show that it's safe to use CCTA and an anatomical test rather than using a functional test like nuclear or stress echo. It decreased the length of stay in the emergency room or in a doctor's office. It decreased the time to diagnosis, which is very important. You know, imagine a patient go through a stress test and then the results are not very definitive and you have to schedule another test. The time to diagnosis become unnecessarily delayed. So it would be very important to shorten the time to diagnosis. And as we all aware, Rendr is very much interested in providing high quality care at the lowest cost. So CCTA in the emergency setting has been shown that it reduces unnecessary admission and the overall healthcare costs. And another very common symptom PCP faces is new onset shortness of breath. Almost every patient over the age of 60 have that kind of symptom. And suddenly say, I don't know why, maybe the COVID, I've been very, not active, very sedentary, and I get short of breath when I was trying to walk. So what's going on? Is this deconditioning, or is this coronary artery disease? So again, data and our own clinical experience tell us that CTA is very, very useful for this. And this is a patient with new onset LV dysfunction, and the echo showed the EF of only 40%, normal being 55 and above. And when we did a coronary CTA, it turned out to be completely normal. And in further questioning, the patient had previous doxorubicin treatment and chest radiation therapy and prior for lymphomas. And, that could cause weakness of the heart muscle, but no damage to the coronary artery. So this patient, basically, all he needs is supportive care. With all the great drugs that we have now, we can treat these patients very quickly and help to preserve the heart function. And coronary anomaly is one of the common findings on coronary CTA, probably more common than in the cath lab, because oftentimes when I was used to doing cath, we cannot find anomaly, because unless you know where to look, there's no way you can find the entry point of the anomalous coronary. But for CTA, you don't have that problem. We see the entire coronary tree with the dye. So we can see things that even the cath lab cannot see. So that is very important. And we see this type of coronary anomaly, in this case, the right coronary coming off the left sinus. And the patient also has the left main disease on top of that. And this is another way of looking at it. We can do MRA, which is also non-invasive, but it's not as quick, and it takes much longer time compared to CTA. And furthermore, MRA, you cannot really see plaque. So that's the weakness of the MRA compared to CTA. The spatial resolution of MRA is also inferior compared to CTA. So if I have a choice, I would use CTA if my question is coronary anomaly. And this is a patient that I saw many years ago and has a single memory graft that he was protecting for his many years. And he worried that this graft going to close. So every year he used to go for cardiac catheterization. And when he met me, I told him, don't do that. Eventually, one of these times, they're going to close the graft just by poking at it. So since then, I've been doing CTA to track the well-being of this bypass graft. And we also use CTA to look at stent patency. Patient after stent, they don't want to go for invasive catheterization to see if it's patent, and we can use CTA if the stent is large enough. We typically can see the lumen if the stent diameter is more than 3 millimeters. So I'm going to switch gear a little bit to talk about MRI, which is another Nobel Prize winner. And this is even harder than CTA. It takes much longer. The physics of MR is very complicated. They generate ultrasound and proton spin from the ultrasound excitation, and then you look at the proton relaxation and to see what kind of tissue that you are dealing with. So it's amazing technology, but it takes time. And but right now, the cardiac MRI is really the gold standard test for the evaluation of heart function. We do a lot of echo, but echo is by no means the gold standard. When you have question, you go to MRI. In fact, if you want to do any clinical trial to look for any effect of certain drugs on heart function, you will not be able to do it with echo. You have to do it with MRI. Otherwise, you will need such a large sample size, become impossible to do. Viability, whether the muscle is alive or not, is a very important question in cardiology. Before you send someone to have a bypass or stent, you better make sure that the muscle is still alive. Otherwise, you are putting stent in a cooked muscle, basically wasting time. We use MRI to measure flow, and this is a very important question in cardiology, whether it's a valvular problem, congenital heart disease. These are common questions that we see and was asked to evaluate even for adult. Many of them have valvular heart problem, and I have seen many times the echo says severe MR, but when I do the MRI, it's only mild. So it is important to have a precise and accurate test in order to treat the patient with confidence. And cardiomyopathy is another very important question in cardiology. When someone comes in with a weak heart, what is the cause? What is damaging the heart, causing the muscle to be weak? And there's really no other test except MRI can do this. And I'll show you some example of how we do this. So MRI is very useful if you have some kind of dysfunction of the heart, whether it's systolic, which is the squeezing part, or diastolic, which is the relaxation part. So either one can cause you to have symptoms of shortness of breath. Cardiomyopathy, whether it's myocarditis or some kind of infiltrated process from amyloid or hemochromatosis or sarcoid, you need MRI in order to evaluate. Valvular heart disease, any one of the four valves, pulmonic, tricuspid, aortic, and mitral, or can be dysfunctional at some time. And echo can give you some idea, but to follow and to assess very accurately, often you need MRI. And congenital heart disease, also another very common group of condition that we see in adult cardiology, because more and more patients survive to adulthood because they had congenital heart surgery when they were a child, and then we now follow them to adulthood, and we need all the tools in the toolbox in order to look at this group of patients and help them to alleviate some of the stress that they worry about, that they will need another surgery down the line. So this is some of the picture that we do using MRI. You can see that there's no blind spot. You can see everything, both the right and the left heart. Typically, the echo is not good for the right heart. You can see the left heart pretty good, but right heart, no good. And this is a patient with pulmonary hypertension, and you need MRI to see this. And viability, there are a couple standard tests we do: SPEC viability, PET viability, and MRI late enhancement. And not just my opinion, the consensus is that MRI has the highest spatial resolution. So it can tell you whether the scar, which is the white area, is complete full thickness or only partial thickness. Of course, more white, more dead, right? So you want the white part to be as little as possible so that you can recommend the patient to have bypass or coronary stenting. The PET imaging looked at the metabolic uptake of the muscle, which is very good. Unfortunately, the resolution is not as good as MRI. SPECT, single photon, is positive electron, is even worse than PET. So if you go down, I would say MR is the preferred, and no radiation, that very, very advantageous. This is a pathology study that compare MR image with an autopsy of a rat. This is not human. They create in the laboratory a scar, and then they do MRI. You can see the laboratory scar is identical to the MRI scar. So that's how accurate MRI is. Basically, it's like a virtual biopsy. And this is to show you the more scar you have, the less functional recovery. So you shouldn't consider sending a patient to have bypass or stent if the scar is transmural. And this is more studies showing how nuclear is pale in comparison with the MRI. Because in nuclear, all you see is just a gaping hole, but the MRI is able to tell you how much, what is the extent of the scar involving. More information is better. In the second row, the nuclear actually looks normal. In fact, there is scarring in the wall. So when the spatial resolution is not that good, you're not going to be able to see the detail, which MRI is going to be able to show you. You see the apical scar also was missed on the nuclear, but pick up on the MRI. So flow is very important. We want to use flow, which is a unique feature of MRI to assess any kind of shunting, leaky valve. One of the area of clinical interest of mine, which is pulmonary hypertension. We use it all the time to assess valvular regurgitation. Is the echo really right? Sending a patient for valve repair is a big deal. So you better be right. You don't want a patient go to have an operation and was told that, oh, by the way, there's nothing to fix. And we see coronary fistula all the time. Which one is clinically significant and which one is not? There's no other way to assess this except using MRI. And this is some of the work that I did when I was at Mount Sinai. We developed the protocol to study systemic flow versus pulmonic flow. This is to help me to assess pulmonary hypertension patients to see if they have severe pulmonary hypertension. And this is the work that I did, and Sinai was published, showing that indeed MRI can be used to assess the severity of pulmonary hypertension based on the transit time. So if someone has severe pulmonary hypertension, the transit time is going to be longer. There's no other way you can do this except using MRI. And this is how you measure the transit time. You use the MRI, you measure the flow, and you measure the time from the beginning of the systole to the end of the systole. That's the transit time. This is what MRI is so useful. Tissue characterization is very important. This is a case from Excelsior when I first joined, that there was a patient with a cardiomyopathy. And I did MRI and I said, gee, this looked like amyloid based on the tissue characteristic of the way that the circumferential infiltration of the abnormal tissue in the heart. This is typical of cardiac amyloid. And this case was sent to Dr. Guo of our hematology department, and then he did a biopsy. And there is indeed elevated plasma cell, and the negative birefringence, the molecular scanning also turned positive for amyloidosis. So we do more than just looking at scarring. We can look for arrhythmogenic right ventricle, which is a common cause of syncope in young patients. So MRI is the only test, I would say, for that. So if you have a young patient in your office, have a lot of PVCs, I would suggest to get a cardiac consult, and we do MRI to see if there's arrhythmogenic right ventricle, which is a fatty infiltration into the right heart, causing instability, and some patients just can die suddenly from an arrhythmogenic right ventricle. So we talk about the myocardial fibrosis and scarring, myocarditis. Now the COVID pandemic, we see a lot of myocarditis, and many patients worry that they have myocarditis, and the only way that you can tell whether they have myocarditis or not is the cardiac MRI. And we talk about amyloidosis. We can use it to look for swelling of the muscle, from edema or from a heart attack. Hemochromatosis from the iron overloading of the heart muscle can also be diagnosed with cardiac MRI. So if you think of MRI basically it's a virtual biopsy of the heart. So in summary, you can divide the cardiac CT, the MR, into sort of two regions. And CT require a better kidney function. And we use the cutoff of 50 for CTA. And MRI, you can do without contrast, then you don't worry about the GFR. If you want to use the gadolinium, which is the MRI contrast, you need eGFR of greater than 30 because you don't want to cause NSF, okay, which is a fibrosis of the skin from a small percentage of individual respond to the gadolinium contrast. And these patients typically have renal insufficiency. So CT is fast, okay, very high spatial resolution. Other than catheterization, nothing can beat this kind of spatial resolution. 250 micron, that's the distance apart of two objects that CTA can see, can tell it apart. MRI, the best you can do is 1 millimeter. So it's almost 1/4 less resolution compared to CT. CT is fast, you can get it done within a few minutes. MRI take at least 30 minutes to an hour. So if a patient cannot stay inside the tube for too long, don't torture the patient with MRI. So there's wider bore MRI, there's an open MRI, but not all of them can be used for cardiac evaluation. The concern with CT is X-ray radiation, of course, and nephrotoxicity. We talk about what we need from the blood test in order to have the patient go for the CTA. MR, same thing, is complex technique. You need expert to do this, not easy. We are one of the few center in the entire New York offer this high level of cardiac imaging. And in fact, we get referral from the hospital because they don't have that kind of expertise. So this is really a whirlwind tour of cardiac advanced imaging in half an hour. And I just want to thank all of you for your attention. I know this is sort of a holiday week and a lot of people are not available, but once I commit to this program, I don't want to just cancel it. So I decided to give the talk because the initial speaker is currently on vacation. So I'm going to stop here and open the floor to anyone with any burning questions.
Thank you for the interesting topic. So I just have a few quick questions. Usually patients are very concerned about the radiation dosage. So if how do we explain to them, in terms of comparing to other imaging modalities, how's the radiation dosage?
Sure. Well, the radiation of CTA depending on the machine. So the better the scanner you have, the lower the radiation dose. When I was in the hospital, hospital have much deeper pocket. So they buy some of the fanciest scanner. So the millisievert of a top line scanner can go down to 1 millisievert for cardiac CTA. Nuclear spec image is about 12 millisieverts, so it's 12 times more than a CCTA. Okay, and if you don't use technetium, if you use thallium, it could be 20, 30 millisieverts. But most nuclear cardiologists will not tell you that you're getting thallium. And to me, is not quite ethical, but that's the way it is. So if you want to ask for the apple-to-apple comparison, even with a scanner that is not state of the art, your dose is comparable to nuclear, a regular nuclear scan. And another way that I use to explain to the patient is that, look, we are not doing this for fun, right? We're doing this because you have a question, and I worry that if we don't answer the question, you'll die. And radiation is not a guaranteed death. In fact, if you fly across the country, you get about 3 to 4 millisievert exposure just sitting in the plane, right? And are you not going to fly across the country? Are you going to drive instead? You know, I mean, these are the questions that for people who don't understand, they sort of exaggerate the risk. In fact, living in New York, you get 3 millisievert a year just living here. You know, the random sunlight or the radiation from everywhere. So it's not like you are living in a radiation-free environment. So if you take that into consideration, it's worth it. You know, at least I know I'm not going to drop that. You go into the cath lab, forget it. First of all, you get invasive. So you got to go through your groin or your wrist. You may die in the cath lab because it's invasive. It also involves dye, and it also involves radiation. Maybe a little less, but in the grand scheme of things, you know, I rather have it non-invasively than invasively any day.
Thank you. That's very helpful comparisons. One more question though. So sometimes when we do low dose screening CT scans, or we do a CT scan for other purposes, sometimes they will report that they see coronary calcifications. If the patients don't have symptoms, do we still refer them for evaluation?
Yeah, I think so. I think this is the whole reason that CCTA saved lives from the Scott Hart trial and the Promise trial that was published in the New England Journal of Medicine a few years ago. If you take two groups of patients, one group gets CCTA, the other group get nuclear stress test or regular stress test. The CCTA group have 50% less chance of dying of a heart attack compared to the nuclear stress test. The reason the investigator of the study said, well, because they see plaque. And when they see plaque, they tell the patient, look, you better start taking your statin. Because if you don't, right now you are not having symptoms, but you may drop dead if you don't lower the plaque burden. Just by showing the patient the CT of the chest, right? That's not even cardiac. And the non-gated study is a little blurry, but it's enough that you know that they're calcium. That alone could save the patient from dying of a heart attack, because the patient now recognizes that he or she has coronary calcification and should be taken care of right away.
Fantastic. Thank you so much.
Okay. Any other questions?
You may have already covered this, and I apologize if it's repetitive, but I would think another concern would be cost.
Yeah. Okay. It's a good concern, but I think CCTA win by a lot. If you compare the cost of a CCTA to a nuclear stress test, is not even close. Nuclear stress test is over $1,500, and CCTA, the government and insurance company, only paid $400 to $500. So it's only cost $500 to do a test, which is a lot more useful and cost less. Because this is the way that the CMS come up with cost analysis based on how much time it takes and what the contrast costs, the machine costs. Nuclear is a lot more. Furthermore, the nuclear lobbyist is very powerful. They've been lobbying for keeping the price as high as possible for as long as I am a cardiologist. So, I don't know why they keep fighting for it. The new guideline already downgrade nuclear to 1B and CCTA move up to 1A. There's no other test as 1A indication except CTA. So to answer your question, yeah, cost is definitely one of my main concern, and Rendr concern. We don't want to use all the money just doing CTA, but I can tell you, you're going to spend more money using anything else. Imagine you if you send a patient with a false positive nuclear, okay, you already spend, let's say, $1,500, and the patient go to the cath lab, and that's going to be $10,000 to $15,000, and it turned out to be nothing. I don't know if you can talk to Dr. Park that this is the way to do it.
Oh, that's excellent. That's excellent information. I actually did not know the different cost breakdown. So thank you very much. That was very informative.
Yeah, thank you. Thank you. Very good question. Yeah. Okay, so any more questions? This is recorded and will be broadcast tomorrow on YouTube. And so you can look for this talk if you miss any specific, and you can always, you see my email on the screen, you can always write me a question and ask me any question. Okay? Well, thank you very much, everybody. Happy holiday and healthy new year to all of you.
Thank you so much.
Thank you. Happy holidays.